for almost everyone, going in for surgery is pretty routine. You put your trust in the medical team, and they take care of everything. But what if for a certain group of people, the very tools that are meant to keep them safe during surgery could actually become a hidden landmine? Imagine this. What if the standard drugs, the normal procedure, could trigger a sudden, profound muscle weakness? It would complicate everything from the surgery itself to your ability to even breathe afterward. Now, this isn't some sci-fi scenario. It is a very real, very critical possibility for patients with a specific rare genetic condition. So let's step into what we're calling the anesthesia minefield. We're going to be talking about a condition called periodic paralysis. It's a rare disorder that turns the operating room into a high-stakes environment where just one wrong move, one single trigger can kick off a major crisis. So what is periodic paralysis really? Well, think of your muscle cells as having these tiny little gates, right? They're called ion channels, and they control the flow of stuff like potassium. In people with PP, these gates are, well, they're faulty. They don't open and close the way they're supposed to. And that makes their muscles incredibly sensitive to certain things. Triggers that can cause sudden, scary episodes of weakness or even full-on paralysis. But here is the absolute most critical detail. Not all periodic paralysis is the same. The specific subtype changes everything. For instance, with hypokalemic PP or hypo-PP, an attack is triggered by things that make your potassium levels drop, like a big pasta dinner. But for hyperkalemic PP or hyper-PP, the triggers are often the exact opposite, things that make potassium levels rise. Understanding which one you're dealing with isn't just a nice-to-know detail, it is the absolute foundation for keeping that patient safe. Okay, so how in the world do you navigate this minefield? It all starts long before the surgery, with what you can think of as a meticulous pre-flight checklist. I mean it, just like a pilot before takeoff. The prep work the medical team does is everything. The safety of the entire procedure is often locked in before the patient even sets foot in the operating room. This checklist really has three main parts. First, you have to do a deep dive into the patient's history. You need to know their exact PP type and what personally triggers their attacks. Next, you screen them with lab work and an EKG to get a baseline. This is especially vital for subtypes like Anderson-Towel that come with heart risks. And finally, you take all that information and you build a rock-solid, concrete plan to sidestep every single known trigger. So what's the big goal with all this prep work? It's to get the patient's potassium level to one very specific target on the morning of the surgery, right around 4.0 millimoles per liter. You can think of this as the safety zone. It's a stable, neutral ground that just dramatically lowers the risk of an attack ever starting. And that avoidance plan gets super specific. These aren't just suggestions, they are hard and fast rules. You schedule the patient as the very first case of the day to avoid long periods of fasting, which can be a trigger. You absolutely forbid any sugary carb drinks. And you even start warming the patient before they roll into the chilly OR, because cold is another huge trigger. It's all about control. All right, we've done our prep. Now we're in the operating room, and this is where it really becomes a minute-by-minute tightrope walk. Every single decision, every drug, every fluid, every breath the ventilator gives has to be made with this patient's unique physiology front and center. The number one rule of this tightrope walk is an absolute one. You must avoid the drug succinylcholine. It's a common muscle relaxant, but in patients with hyper-PP, it can cause a massive, life-threatening spike in their potassium. Because of that, it's just considered completely off-limits. No exceptions. So, with some drugs off the table, what are the safe plays? Well, the gold standard is often a technique called total intravenous anesthesia, or TIVA. By using IV drugs like propofol, you can completely avoid the risks that can come with inhaled anesthetic gases. And when it's time to reverse muscle relaxation after the surgery, a newer drug called Sugamedics is the real hero here, giving a much cleaner and safer wake-up. Throughout the whole procedure, the team is laser-focused on maintaining what we can call a safety triangle. First corner, normothermia. You got to keep the patient warm because cold is a known trigger. Next corner, normocapnia. You have to keep their CO2 levels perfectly stable because even small changes in breathing can dangerously shift potassium. And the final corner, normoglycemia. Keep blood sugar steady, which means no sugary IV fluids, period. And how do they possibly maintain that perfect balance? Through constant, relentless vigilance. This is not guesswork. It requires real-time data from blood gas and electrolyte checks, sometimes as often as every half hour. It's the only way to truly see what's happening inside the patient's body and steer the ship safely. But what if, despite every single precaution, an attack starts to happen? This is where the team has to pivot to a clear, life-saving emergency protocol. If it's a low potassium or hypokalemic attack, the response is straightforward. First, you stop whatever might be triggering it. Then, you carefully give IV potassium, all while watching the patient's heart like a hawk. Now, for a high potassium, a hyperkalemic attack, the response is the complete and total opposite. Instead of giving potassium, your goal is to force it out of the blood and back into the cells, using a combo of dextrose and insulin. This right here, this slide, it is the clearest example of why knowing the patient's exact subtype isn't just important, it is a matter of life and death. So, the surgery is done, the patient is starting to wake up. You'd think everyone could relax, but the danger isn't over yet. The recovery period is an incredibly critical window where the risk of an attack is still high, thanks to things like post-op stress, pain, and shivering. That's why this post-operative vigilance is so important. In the recovery unit, the patient is monitored incredibly closely for hours, with those electrolyte checks continuing. The team works hard to manage any new triggers, like pain or shivering, to make sure the patient has a smooth and safe transition back to stability. Okay, so after walking that incredible tightrope, what's the ultimate safety playbook? Let's boil everything we've talked about down to the absolute essential, golden rules for managing these incredibly complex cases. Here it is. This is the ultimate takeaway. Rule number 1, and it's worth saying a third time, no succinylcholine, ever. Rule 2, maintain that safety triangle. Normal temperature, normal CO2, normal blood sugar. 3, check potassium constantly. And the last few rules are all about making the safest possible drug choices. Use Tiva when you can, precisely monitor muscle relaxation, and always prefer Sugamidex for reversal. This is the blueprint for success. You know, this whole situation reveals a really crucial idea in medicine today. For some patients, safety isn't something that's improvised in the moment. It's built on a meticulous, detailed plan that's created long before they even arrive at the hospital. Which kind of leaves us with one final thought to chew on. What other hidden conditions are out there, lurking just beneath the surface, that demand the same extraordinary level of preparation?